Despite the normalcy of childbirth, complications may arise that will have detrimental effects on the postpartum client. These include postpartum hemorrhage, thrombophlebitis, infections, and postpartum depression. Healthcare providers working with postpartum clients must have a clear understanding of these complications, including the symptoms, nursing interventions, and treatment. Postpartum hemorrhage is one of the leading causes of death among postpartum clients. Postpartum hemorrhage refers to a blood loss of more than 500 milliliters after a vaginal birth and more than 1,000 milliliters after a C-section. Postpartum hemorrhage is categorized as early or late. Early refers to a hemorrhage occurring within the first 24 hours after birth, while late refers to a hemorrhage occurring after 24 hours. Blood loss exceeding 1,000 milliliters is considered physiologically significant and can result in hemodynamic instability. Even with appropriate management, approximately 3% of vaginal deliveries will result in severe postpartum hemorrhage. It is the most common maternal morbidity in developed countries and major cause of death worldwide. The amount of blood loss may be either estimated by caregivers or assessed using an array of modalities, which includes alteration in lab results, such as hemoglobin or hematocrit levels, mechanical means, such as drapes or pad counts, radioactive methods, and dye dilution techniques. It has become obvious that the more accurate methods are not readily suitable to the setting of life-threatening situations due to their complexity, unavailability, and cost. Real-time approximations are used and thought of as the most valuable means for early detection of hazardous blood loss. The accuracy of blood loss estimation in real time is frequently underestimated by approximately 50%. This can cause misleading judgment for appropriate management and delayed treatment. Early postpartum hemorrhage is often caused by uterine atony. The uterine atony, there is a failure of the uterine muscles to contract properly, thereby inhibiting the healing of blood vessels at the site of placental attachment. The blood vessel continue to bleed until the uterine muscles contract. Signs of uterine atony include a boggy uterus, a fundus that is higher than expected upon palpation, and excessive lochia. Complications from postpartum hemorrhage include orthostatic hypotension, anemia, and fatigue, which may make maternal care of the newborn more difficult. Postpartum anemia increases the risk of postpartum depression. Blood transfusions may be necessary and carries associated risks. In the most severe cases, hemorrhagic shock may lead to life-threatening complications or death.
Every postpartum client has the potential to hemorrhage after delivery. However, some clients have attributes that place them at higher risk for postpartum hemorrhage. These risk factors include multiparity, multifetal pregnancy, macrosomia, prolonged or precipitous labor, labor induction, vacuum or forceps delivery, lacerations, stillbirth, placental previa, the use of certain medications, for example, magnesium sulfate, and mechanical factors such as a full bladder. Labor that was induced or augmented with oxytocin is more likely to be followed by post-delivery uterine atony and hemorrhage. Early postpartum hemorrhage can also be caused by damage to the birth canal during labor and birth. If an early postpartum hemorrhage is due to trauma to the birth canal, such as a hematoma, an extension of a perineal incision, or an improperly sutured laceration, clients may exhibit one or more of the following symptoms: a contracted uterus with excessive lochia, bright red lochia, a constant trickle of blood from the vagina, severe pain, possibly from a hematoma, or shock. In the case of an early postpartum hemorrhage caused by damage to the birth canal, surgical repair is usually necessary. In the case of hematoma formation, surgical incision, evacuation of blood clots, and ligation of the bleeding blood vessel may be necessary. However, in the case of a small hematoma, observation and application of ice or alternating hot and cold applications may be all that is necessary. If the fundus is not firm, there are several nursing interventions that can alleviate the problem. Massage the uterine fundus. Express blood clots only if the uterus is firmly contracted. Otherwise, uterine inversion and severe hemorrhage can occur. Encourage the client to void or catheterize as needed. Administer prescribed medications such as Pitocin or Methrogen to assist the uterus in contracting. Methrogen can cause an elevation in blood pressure and should not be used with hypertensive clients. Saturating one pad in less than an hour, a constant trickle of lochia, or the presence of large blood clots is indicative of more serious complications and should be investigated immediately. A significant amount of lochia, despite a firm fundus, may indicate a laceration in the birth canal, which should be addressed immediately. The nurse must report a postpartum hemorrhage immediately and prepare for the insertion of a large bore intravenous catheter, if one is not already present, and the administration of IV fluids and oxygen. A large bore IV catheter is inserted to allow possible administration of blood products. The nurse should assess continually for bleeding changes and vital signs and oxygen saturation. The client's legs may also be elevated to a 20 to 30 degree angle to increase venous return. Clients and their families will need nursing support during a postpartum hemorrhage.